Okay. Welcome everyone. Again, welcome to the NANS 2 workshop. And I think we've got everyone in, so we'll get started in order to keep to time this morning. I myself, Bríd McNulty from UCD, would like to firstly welcome Dr. Jeanette Walton, who's going to start the workshop for us and do the welcome and introduction. So Jeanette, if you want to turn on your audio and video now, and we can get started.
Thank you very much, Bríd. Can I just check, can you see my full screen and hear me okay?
Perfect. Yeah, everything's perfect, yeah.
Thank you. Welcome everybody this very cold morning. It's -5 degrees here in Cork. And we'd like to welcome you to our stakeholder workshop on our new National Adult Nutrition Survey, National Adult Nutrition Survey 2. And I'm just going to share with you just an introduction on our surveys and the methods particularly used for this survey before I pass on to Laura and Maria to share some of the key findings. So in terms of nationally representative food consumption surveys in Ireland, we've been very, very fortunate in Ireland to be completing food consumption surveys now since 1997 to 99. And this is our third adult survey. And we also have at this stage completed 2 surveys on school-age children and 2 surveys on teenagers. And we're delighted to be able to share the news also today that we have successfully received funding from the Department of Agriculture, Food and the Marine to complete a new preschool survey, and we'll be starting that early this year. But for today, we're going to focus in on our second NANS survey. And in the original North-South of Ireland food consumption survey, we had only 18 to 64-year-olds, so it was the younger adult population. But in both the 2008-2010 survey and in the one we're going to talk about today, NANS 2, we also have our older cohort of over 65s. So it's great to have that data for comparison. Many of you here today or watching this on recordings later will be very familiar with our food consumption surveys. And an important note, I think, to mention and remind us all is that these surveys are designed not only for nutrition, but also and mainly for food safety. And while we call them nutrition surveys, really, I suppose, if you think about it, they're food consumption surveys, and the data that we collect relates to the consumption of food, the nutrients then that provides, but also all of the other things that food provides, and the health and lifestyle factors of our population as well. Our surveys, we're very fortunate to be funded by the Department of Agriculture, Food and Marine. And as I say, we've just recently got funding again from the department for a new survey, and we're very thankful for that. Our users of data are very broad. They're typically in Ireland, the data are used by the Food Safety Authority of Ireland to answer a number of their questions in relation to dietary exposures and food safety, used by Safe Food, the HSE, the Department of Health. They're widely used by industry and in academia. And we're finding more and more that our surveys are now being used not only nationally, but internationally. And they're internationally recognized due to the quality of the data that are collected and the quality of the methodologies used. To give a couple of applications of the surveys, one of the key purposes of the survey is to allow us to look at food chemical intake assessment. And this is typically done by the Food Safety Authority of Ireland with support from researchers within Ireland. And some of those chemical intakes would include additives. We would look back at raw agricultural commodities to look at pesticides. We collect detailed data on the actual packaging that the food comes in as well. So we're able to look at any contaminants or exposure to packaging itself, which might migrate into the foods. And we look at contaminants also, including heavy metals. So both the Food Safety Authority of Ireland and EFSA, the European Food Safety Authority, use these data routinely to answer questions in terms of food safety. In terms of nutrition policy, these data are used widely, again, nationally and internationally, in terms of informing food-based dietary guidelines on in terms of portion size and dietary patterns, which should help to reduce body weight. The data are used to understand the benefits and possible risks of food fortification or nutritional supplement use. And also the data are widely used by industry in terms of development and promotion of healthier products. And wider than this, again, the data are used to inform curriculum, even at second level, where we have found in recent times in 3 home economics papers at higher level, data from these surveys have been used in the exam questions. So this will then inform the curriculum and what's taught in the home economics curriculum. We've seen the data be used in terms of advancing science, in terms of both methodologies and interpreting data, not only nationally, but globally. And we've also seen our researchers being very well trained to take on roles in nutrition, health, food industry, and academia at very high levels. So the applications of the INA surveys go much wider than the data, but there's just a few examples here of some of the applications of them. To talk today, as I know everybody's really wanting to hear the results and not to hear about the methods, but the methods are very, very important in terms of understanding the results. And I'd like to talk to you just for a couple of minutes on the study design for NANS 2. NANS 2 was always ambitious. The intention from the start was to collect data on 1,000 adults and to collect data, interpret it, and provide a summary data within 3 years. And this was all going well. Ethics was approved. And suddenly we were hit by a global pandemic, which caused a little bit of, I won't say confusion, but a bit of an outburst for the whole population, for the whole, not just the population of Ireland, obviously, but globally. And research probably came down people's priorities for quite a while. We had already got our ethics approved, and we were in a situation where we went into a level 5 lockdown, and with advice, and very good advice, we had to completely rethink the whole survey. And we'd like to thank, I suppose, at this point, Helen and the team in the Department of Agriculture, Food and Marine for their trust and patience with us as we completely rewrote the ethical proposal, and of course to thank the Ethics Committee again for their trust in us to complete a survey during a time when the country was in absolute turbulence. So to give you a few methods of how we actually completed the survey during this time of the pandemic, obviously we weren't able to complete anything during the level 5 lockdowns, but as soon as we came out of level 5 and we were able to travel, we continued the survey throughout the pandemic times. Our sampling plan we used, similar to the previous National Adult Nutrition Survey, was from the UNPUST Geodirectory, and we used the Social Deprivation Index to support that, to ensure that we could get as close as possible across the band of social classes that we could. We sent a letter to the household. Our initial intentions would have been to follow up to the houses, but due to social distances and the restrictions that came with the pandemic, ethics wouldn't allow for any cold calling. So there was no cold calling. A letter went to the household, and the householder had to opt in via permission to contact form in order for us to make any contact whatsoever with that participant after the initial letter. And that was a very strict regulation from ethics. When the permission to contact form came back, the study coordinator contacted that household with a hierarchy of who could be recruited from that household. So it wasn't necessarily the person who returned the letter that we wanted within a household. So there may have been somebody really eager, really interested in nutrition who wanted to take part. But again, if they weren't on our list of the, male, female of certain age groups within that household that we needed, then they weren't taken on board. So that again added to our recruitment issues. That hierarchy was done on sex and age, by sex and age group. The fieldwork phase of the study took place in April 2021 until August 2022, which gave us a nice seasonal balance, but almost a year and a half on the field during very difficult times. I'm delighted to be able to tell you today that we have 1,000 participants recruited, with a balance of 49% males and 51% females. And according to the census and the breakdown that we wanted from our sampling plan, 72% of the 19 to 64-year-old age group and 28% of the older adults, 65 years and over. And I know there are study coordinators and field workers here very proud to tell you that our oldest participant was 92 years of age. Our response rate of eligible participants in the survey was 61%. And the sample that we have is demographically representative of the Irish population in terms of age group, sex, and urban-rural location. However, as per previous surveys, and not unexpected, the social class was higher, with a higher proportion of professional workers and a lower proportion of semi-skilled and unskilled. But all the data that you'll see today and that will come out of the survey are weighted to account for these differences. In terms of the actual methods that we used to collect the data, and again, these changed due to new ethical approval. Our original intention was to move to 224-hour recalls as recommended by EFSA for collecting food consumption data for adults. However, these had intended to be face-to-face, but again, due to an updated ethics application and acceptance, these 24-hour recalls were by telephone. All 24-hour, so per person, they were 7 days apart and different days of the week wherever possible, but 2 24-hour recalls were collected for each of the 1,000 participants. A food atlas was provided in advance. So in terms of quantifying the food consumed, the participant did have a food atlas in front of them when they were when the data were being collected by 24-hour recall. We also collected a food propensity questionnaire to capture episodically consumed foods. This is really important when we've only 2 days of data collection, and again is included in the methods recommended by EFSA for dietary exposures. In terms of nutrient intakes, we use Nutritic software, and which contains UK food composition tables, and we supplemented that with our own food composition databases that we put together throughout the survey. In terms of other data collected, because we weren't allowed call to the house, so it's self-measured height. We provided a tape measure for the participant, and they took their own weight with their own scales. If somebody didn't have a household scales for body weight measurement, we offered to provide one for them. In terms of physical activity, food choice, and eating behavior data, these data were collected with validated questionnaires. We collected a single morning urine sample from each participant to estimate sodium and salt intake. And we collected a dry blood spot sample from the participants in order to hopefully have some analysis in terms of vitamin D, folate, and iron status for the Irish population. So to sum up where we are in terms of those methods and where the obstacles really were, in terms of recruitment, these were really big obstacles. No cold calling opt-in. So therefore, we had to rely on the participants wanting to take part. And the random selection hierarchy certainly took some bias out of that and was really important, but it did lead to recruitment being really, really difficult for both the coordinators and the field workers. We were in complete times of social distancing. We weren't allowed to meet the participants. So all field work was done by drop and collect. So the participants left there, or the field workers dropped packs to the participant into hallways, outside doors, wherever, and they collected in the same way. And again, this was a time of masking, sanitizing. All of the food atlases and anything else that we provided for participants had to be sanitized in plastic containers or plastic packaging. And we really were extremely strict with those hygiene rules at this really difficult time. Telephone interviews versus face-to-face interviews. Again, we obviously would have preferred to be in the people's houses, collecting the data by face-to-face. But the 2 telephone interviews for each participant were really, really detailed and really comprehensive, and it's a credit to the field workers. Collecting dried blood spots instead of venous blood, again, is technically something of an obstacle, but it will allow us to look at some future research in this area to see, can we analyse these really important nutrients with dry blood spots and what data we can get from it. So we're bringing research forward here in this way, and we won't be presenting data on that today, but over the coming time, we look forward to being able to see more information on dry blood spots compared to venous blood in terms of vitamin D, folate, and iron status. I think we should just focus in on the important strengths of the study and where we haven't lost important data, despite all these obstacles. The survey was still researcher-led with trained nutritionists, which had a lot of rapport with the participants, even though they weren't able to meet them per se. There was 3 socially distant visits, and we can evidence that, we can evidence the really good rapport by being absolutely delighted to tell you that we got 997 of these participants provided a urine sample. I mean, and that is just a huge, huge credit to the team collecting that data, and showed the rapport with the participants. And 82% of those who were eligible to provide a blood sample provided a dry blood spot as well. So again, you can really see that there was rapport there within the survey. 2 recalls were collected for all participants. So we have complete data for everybody in terms of food intake. And I think it's really important from a quantification point of view to acknowledge the fact that food atlases were provided, and where they weren't able to give data from a food atlas in terms of quantifying their food, they were able to give household measures, and really, really importantly, packaging data were collected, which helped with both the food descriptor and the quantification. So while the survey wasn't ideal, and in terms of methodology of where we would like to have been, I really feel that we can really stand over what we're presenting today and to the future in terms of the data collection. Preliminary findings that we're going to share today will be on food and nutrient intakes, motivators of food choice, barriers to healthy eating, data on body weight and the prevalence of overweight and obesity, and some data on physical activity. And more further analysis is ongoing, will be ongoing for a long time, and detailed methods and outcomes will be available on our website. We normally leave the acknowledgement slide to the end, but I really felt that it would be remiss of me not to acknowledge the teams at this point when we talk about the detailed methodologies during a time that was difficult for everybody, not just in their professional lives, but in their personal lives as well. And I'd like to put a particular shout out to the field workers in Cork, Niamh Walsh and Cliona McGowan, and in Dublin, Emma Kane and Caroline Donovan. And these teams led by Dr. Emma O'Sullivan and Dr. Laura Keogh in Cork, and Dr. Maria Buffini in Dublin. And I think it would be very remiss not to mention these really, really hardworking teams who were out in the field for an hour, I was going to say an hour and a half, a year and a half during these really difficult times. And while I'd like to acknowledge everybody on this slide, I'd particularly like to mention those. And that leaves me to say, if anybody has any questions, please put them in the question and answers. And if anybody would like to comment or tweet any of the findings as they come up, please use our hashtag NANS2. And I'll hand you over to Laura to start some of the preliminary findings, and thank you for listening.
Thanks very much, Jeanette. I'm just going to share my screen for everyone here now. Okay, just confirm you can see my screen okay?
Laura, it's just in the
Wrong one.
other view, so if you want to change it.
Sorry to share, stop sharing. No?
Yeah, that's perfect.
Perfect. Okay, good morning, everyone. Thanks very much, Jeanette, for covering some of the background and the methods on the National Adult Nutrition Survey too. So I'm delighted to be here on behalf of the entire team that was mentioned to present some of the preliminary findings on what are adults in Ireland eating. So I'm going to give you some brief overview of the key findings on food and beverage intakes, energy and nutrient intakes, and some top level messages from both our food choice and eating behaviour findings as well. So first of all, I'm going to talk you through our food and beverage intakes in adults in Ireland. So we found the staple foods, and these are foods that are consumed by large proportions of the population and that are making important contributions to nutrient intakes later on, were your breads, potatoes and cereals, your dairy and non-dairy alternatives, meat and meat products, fruits and vegetables. And as I go through this presentation, I'll present to you some of the main findings on each of these individual food groups. So first of all, if we take a look at bread intake. So all of these slides will follow a similar format, but what I will do first is I'll show you the percent consumers, and we'll present this in the younger adults aged 19 to 64 years, and in the older adult category, those who are equal to or above 65 years of age. Just to note that the percent consumers that we present here today is data directly from those who consumed the food during the 2 dietary recalls. We have yet to take a look to incorporate some of the food propensity questionnaire data to look at percent consumers, but these are those who consumed the food during the 2 dietary recalls. And we found that bread was consumed by over 93% of adults in both age groups. Then what I'll do on each of these slides is I'll present this graph of intakes. And again, on the vertical axis, we'll have the grams per day, and you'll see the 19 to 64-year-old category on the left-hand side and the over 65s on the right-hand side. And these data are calculated using the usual intakes of foods, and this has a food propensity questionnaire data incorporated to account for the fact that the 2 24-hour dietary recalls may not have captured someone's true intake of every single food group because it's only a 2-day recall. But here we can see the bread intake. So you can see on the graph the younger adults on the left and the older adults on the right. The average daily intake of bread was about 2 slices per day for both age groups, about 85 grams per day for both. And you can see that there was a roughly equal breakdown of both white and wholemeal or brown bread in both the younger and older adults. When compared to the previous NANS, we know that there's a lower bread intake compared to previous. There's about 115 to 120 grams consumed by these age groups in the previous NANS, but the split between white and brown has remained relatively similar over time. Next, we're going to take a look at grains, rice, pasta and potatoes intake. And our pasta, rice and savouries consumers, in the 19 to 64-year-old category, we had 65% of those adults consuming pasta, rice and savouries, with 44% of adults over 65 years consuming pasta, rice and savouries. While then for the potatoes and potato dishes, we had 67% of the younger age category consuming these, and up to almost 90% of the older adults consuming potatoes and potato dishes. And when we look at the intake, here you can see on the graph, the intake of potatoes, pasta, rice and savouries is about 130 to 140 to 150 grams per day in both age groups. In the younger age category had a roughly equal split of intake of pasta, rice and savouries compared to potatoes and potato products, while the older adults still had a higher intake of potato and potato products. more like the traditional diet. When we compare this to previous NANS, the overall intake of potatoes is lower, and the intake of grains, rice, pasta, and savouries is higher. And this is particularly notable in the younger age group as well, but is true for both age groups. In terms of other cereals and other cereals that in the context of carbohydrate-based foods, we have here the porridge and hot oat cereals and ready-to-eat breakfast cereals consumers. So collectively, for both those groups together, our younger adults, 1964, 60% of them consumed either ready-to-eat breakfast cereals or porridge and hot oat cereals, and these have been made up consumed with milk or water, or however it might be. And our over 65s, they consume 79% of those consumed ready-to-eat breakfast cereals or porridge and hot oat cereals. And here on the graph on the left-hand side, you can see the intakes. So the younger adults had a lower intake in total of ready-to-eat breakfast cereals and porridge. And interestingly, they had consumed more porridge compared to ready-to-eat breakfast cereals. When compared to the previous NANS, this is a shift away. There's been a reduction for the younger adults in ready-to-eat breakfast cereal consumption and an increase in porridge and hot oat cereals consumption. The older adults have remained relatively similar to previous, with about 14 grams per day of ready-to-eat breakfast cereals being consumed and about 83 grams of porridge being consumed, which is very similar to the previous NANS. In terms of dairy and non-dairy alternatives intake, our milk consumers, so we had 84% of adults aged 19 to 64 consuming milk, and we had 90% of those over 65. And the intake of milk was about 150 grams or milliliters per day in the younger adults, compared to just under 200 mils in the older adults. So about 3/4 to 1 glass per day. And you can see for both of the age groups, the breakdown between whole milk and low fat 1% or skimmed milk is about half or about equal contribution from both groups. Overall milk intake is lower, particularly in younger adults, compared to the previous NANS, while the older adult intake has remained relatively similar. And previously, the breakdown was also quite similar in younger adults, but the older adults previously had a higher intake of low fat and 1% in skimmed milk, and now it's about half and half for whole milk and low fat skimmed. In the context of yogurt and cheese, our younger age category, we had 38% of them consuming yogurt and 62% of them consuming cheese. And our older adult category, there was 43% of them consumed yogurt and 54% consumed cheese. And you can see here the 19 to 64-year-olds consumed about 39 grams of yogurt and 15 grams of cheese, and similar intakes in the older adult category as well. When we looked at dairy intake, and this is just from discrete milk, yogurt, and cheese, not including anything that might be in composite dishes, we can see that both age groups are getting just approximately 1.3 portions of dairy per day, which is quite low in comparison to the guidelines. We do know when we take a look at composite dishes, there may be some cheese or milk, etc., included in certain dishes that might add to this, but from a discrete intake, we are not meeting the guideline for either younger or older adults. In terms of meat intake, our meat consumers, so we had 90% of adults aged 19 to 64 years consuming meat, and we had 87% of adults over the age of 65 consuming meat and meat products. And in terms of the intake, we had an intake of meat and meat products, and I've also put on this graph meat alternatives, including meat alternative dishes, just to show you that these are coming into the diet and making up a portion of foods that are consumed either like meat or in the place of meat. But the intake of these four groups collectively together is about 150 grams per day. And you can see that this is made up by meat dishes in the blue, fresh meat in the orange, processed meat in the grey, and then those meat and alternative dishes. When we take a look in comparison to the previous survey, the lower intake of total meat, there is a lower intake of total meat for both ages, but it's particularly prominent for the younger age category again. And this is mostly attributable to a slightly lower intake of processed meat. And these processed meats that I'm talking about in this context, it's not the IARC definition, but rather your bacon and ham and your processed meat pies and products. But you can see that these meat alternatives are coming into the diet in place of these, and we know from various research that these may not necessarily have a better nutritional breakdown overall. So next, if we take a look at fruit and vegetable intake, so we had over 96% of adults of both ages consuming fruit and vegetables across the 2 recall days. And when we take a look at the intake here on the graph, you can see fruit and fruit juices is in the blue, discrete fruit in the orange, vegetable dishes in the grey, and discrete veg in the yellow. And the average daily intake for both younger and older adults was about 280 grams per day from every source. So this is including all the fruit juice and smoothies that were consumed. These were not limited in this intake graph. But if we count total intakes, that 280 grams per day, we can see that the total intakes are low with respect to recommendations. They're getting about 3.5 servings per day on average, and bearing in mind that the recommendation is 5 to 7 servings of fruit and vegetables per day. When we took a look at meeting at an individual level of those who are meeting the recommendation, we took a look at those who are meeting the 400 gram minimum intake of fruit and vegetables per day, limiting the fruit juice and smoothies to 100 mils or 1 portion per day for those who consumed it, as according to the Irish Food-Based Dietary Guidelines. And we found that just 1/5 of adults are meeting this recommendation of a minimum of 400 grams per day. And interestingly, another 1/5 on the other end of the scale are not even getting 1 portion. They're not even meeting 80 grams per day of fruit and veg. When we look to compare this to the previous NANS, we can see that fruit and veg intakes appears to have increased a little bit over time. When we looked at the prevalence of those meeting the recommendation in the previous NANS, it was about 9 and 18% for the age group. So we can see that there's a little bit of an increase in those who are meeting the recommendation over time. In terms of beverages, water was the most commonly consumed beverage amongst those aged 19 to 64 years, and tea was the most commonly consumed beverage amongst those aged over 65. While not the most commonly consumed beverage amongst these adult age groups, I've put up this soft drink intake just for references. This is also always very interesting in the context of sugar sweetened beverages and sugar sweetened beverage intake. So we can see that the intake of soft drinks in total for the younger age category is about 180 grams per day compared to about 100 grams in the older adults. But we can see that in both of them, the majority of this soft drink intake is coming from no added sugar rather than the added sugar component. In terms of confectionery and snack intake, confectionery and snacks were consumed by 95% of those in both age in the younger age category and 94% in the older age category. They had an average daily intake of 74 grams per day in the younger adults and 65 grams per day in the older adults. And the confectionery was consumed in all forms, but the most common most common groups that were consumed included biscuits, cakes, pastries, chocolate, your preserves and spreads, and savory snacks such as your crisps. And as these are increasingly coming on the market, things like cereal bars with added protein or added fiber or fiber type bars, we looked at how many of our adults consumed these particular types of products, and 12% of adults in the 19 to the 64-year-old category consume these, with minimum intake in the older age category. In terms of supplement use, so here on the left-hand side, I'm going to talk you through the findings from the 19 to 64-year-olds first. So we found that 53% of our 19 to 64-year-old adults used a supplement during the 2 24-hour dietary recalls. And the most common types of supplements that were used by this age group was multivitamin and or mineral supplements, single vitamin D supplements, fish, linseed or primrose oil, and then botanical and herbal and single vitamin C supplements. In terms of our older adults, we had almost 60% or 59% of them who used supplements during the 2 24-hour recalls. And the most common types of supplements that were used by this age category were your single vitamin D supplements, then your multivitamin and mineral, your fish, linseed and primrose oil, your vitamin D and calcium supplements, and then others. So this is an interesting distinction between the two age groups and the messages that they might be getting behind supplement use. Then to take a look at the two supplements for which we have recommendations for this adult age group here in Ireland. And first, I'm going to take a look at our vitamin D supplements. So in the 19 to 64-year-old category, we had 39% of these adults taking a vitamin D containing supplement. And the median intake that those users were getting from supplements was 15 micrograms per day from supplements. In the over 65s, we had 49% of these adults using a vitamin D containing supplement with a median intake from supplements of 20 micrograms per day. In terms of folic acid supplement use among women of childbearing age, we found that just 7% of women of childbearing age were obtaining 400 micrograms of folic acid from a supplement per day. So that's to sum up our food and supplement use and our main findings there. And now I'm going to talk you through our findings on energy and nutrient intakes. So first of all, I'm going to show you our energy intake. So our sources of energy, sorry, apologies. So here on this graph, you will have the 19 to 64-year-olds in blue and the over 65-year-olds in orange. But we can see that the key contributors to energy intake were meat and meat products, breads and rolls. Then with other groups such as grains, rice, pasta, sugars and confectionery, biscuits, cakes, pastries, beverages, milk and yogurt, making important contributions to energy intake for both younger and older adults. When we looked at top shelf foods, so top shelf foods talking about biscuits, cakes and pastries, sugars, confectionery, preserves, and your beverages such as sugar sweetened beverages, about 20% of energy intake for both younger and older adults was consumed from top shelf foods. And when we took a look at the calories that were consumed outside the home, we found it was 15% of calories consumed from outside the home in the younger adults and about 13% in the older age category. To take a look at protein, fat and carbohydrate intake, I have the 19 to 64-year-olds on the left-hand side and the 65-year-olds on the right-hand side. But here we can see the breakdown, the percent of energy that was coming from protein, total fat and carbohydrate in both age groups. And this is the breakdown of food energy. But we can see that total fat intakes were about 37% of energy intake for both of the younger and older age categories. And this is above the recommendation of less than 33% of food energy from total fat. Our carbohydrate intakes in both age categories were about 44%. Which is below the recommendation of 50% food energy and carbohydrates. So we have lower intakes of carbohydrate than recommended and higher intakes of total fat. And while this is food energy, just as it may be of interest, when we talk about total energy intake, alcohol contributed about 4% of total energy intake on average for the population for both age groups. Then to take a look at saturated fat intakes. So here on the graph, you can see the mean intake of saturated fat is about 13% of total energy in the younger age group and 14% in the older age category. And this is similar to previous, when we compare to the previous NANS. But when we compare this to the recommendation of less than 10% total energy intake, we can see that this is above the recommendation still. The key sources of saturated fat included meat and meat products, your biscuits, cakes and pastries, cheeses, milk, butter, spreading fats for both age categories. In terms of sugar intake, we found that total sugars intake is 17 and 18% of total energy in both younger and older adults. And while these are just very preliminary estimates, as we have not completed the full coding of free sugars, but we can say that preliminary estimates show that intakes of free sugars is approximately 8 to 9% of total energy intake, which again is quite similar to the previous findings from NANS 2008-2010. The key sources of total sugars included fruit and fruit juices, sugars, confectionery, preserves and savoury snacks, milk and yogurt, beverages and biscuits, cakes and pastries. And again, when we've completed the full coding of the free sugar intake, and we will be putting that out there, you can see that the key sources of total sugars, such as things like fruit juices, sugars, confectionery, preserves, savoury snacks, some yogurts, some sugar sweetened beverages, and biscuits, cakes and pastries, are likely to be large contributors to free sugar intake as well. In terms of dietary fibre intakes, The average daily intake among both the younger and older adults in the survey was 18 grams per day. And this is similar to the previous intake in NANS 2008-2010. And unfortunately falls well below the recommendation of 25 grams per day, which is an adequate intake recommended by EFSA for normal bowel function. And the key source of dietary fiber for these two younger and older adult categories were bread and rolls, vegetable dishes, fruit and fruit juices, breakfast cereals, grains, rice, pastas and savouries, and potato products. In terms of salt intake, as Jeanette mentioned in her presentation, we collected a first void urine spot samples from almost all participants in the survey, and this allowed us to estimate urinary salt excretion. Urinary salt excretion allows us to estimate the total salt intake. So when we capture dietary salt intake, we're unable to capture any salt that might be added at the table or in cooking, which is called discretionary salt, whereas urinary salt excretion captures everything. And we can see that based on these first void urine spot samples, the urinary salt excretion was about 9.4, 9.5 in males of either age category, and was 7.8 grams per day for females 19 to 64 and 6.5 for females over 65. When we take into account that the recommendation is for a maximum target population intake of 6 grams per day, we can see that we're still above these recommendations across all age categories. And when we compare this to the previous NANS, our urinary salt excretion has reduced by about 1 to 2 grams per day, depending on highest in males, depending on the group that you're looking at. But we did also find when we looked at the dietary salt intakes, that the dietary salt intakes were lower, again by approximately 1 gram, depending on the age group that you're looking at. With the key sources of salt were similar in both age groups, which are meat and meat products, such as primarily your cured and processed meats, being a key contributor, bread and rolls, and then your soups, sauces, and miscellaneous foods also contributing to salt intake in the diet. In the context of micronutrient intakes, here today I'm just going to present you with the proportion of adults who had an adequate micronutrient intakes. So inadequate micronutrient intakes is the prevalence of the population with micronutrient intakes below the estimated average requirement for that particular nutrient. And we can see for vitamin D here, again, with the 1964-year-olds in blue and the over 65s in orange, we can see the prevalence of inadequate vitamin D intakes was 66% for the younger adults and 53% for the older adults. This is a reduction on previous, compared to the previous NANS when we had about 90% inadequate intakes. And as I mentioned on our supplement side, this is largely being driven by a higher number of supplement users and the amount that they're getting from supplements, regardless of which we still have over half the population who have inadequate intakes of vitamin D. We had about 40% of adults in Ireland having inadequate intakes of vitamin C, about 36 to 37% folate. About a third of adults in both age categories had inadequate calcium intakes. Similarly, about a third for zinc. 23 to 25% had inadequate intakes of vitamin B6. About a fifth had inadequate intakes of riboflavin. About 16 and 13% had inadequate intakes of vitamin A. For iron, we presented the female data only because it's quite striking to see that we had 17% of younger adult females and 13% of older adult females having inadequate intakes of iron, and we had small proportions having inadequate intakes of vitamin B12. It's interesting to note that females aged 19 to 64 years had a higher prevalence of inadequate intakes for riboflavin, vitamin B6, calcium, and iron compared to males. So that's to sum up our energy and nutrient intakes, and now I'm going to present to you just a couple of our key findings on our food choice and eating behaviours. So food choice and eating behaviour was collected through a questionnaire which was self-administered and participants filled it in themselves. One of the first things I want to present to you today is the most important factor when selecting foods. So participants were asked to rank these factors in what was most important to them when they choose foods. And you can see here that taste was the #1 factor that came the most important when they were choosing food, followed by nutrition and health. So these findings suggest that the health is important to adults in Ireland, but most will not compromise on taste when making their food choices. We can see other factors were much lower, so convenience and preparation, cost, price, interest, and the impact on the environment didn't have quite as big an impact as might be expected, or sport and optimal performance was very low, as it might be for some of the adults, it might be a factor. A second key finding we have from our eating behaviour is our perceived barriers. So what were the biggest barriers to adults in terms of consuming a healthy diet? So the biggest barrier was convenience, then it was likes and dislikes, cost, availability, food advertising, and then a small portion of allergies. So we can see Irish adults have an interest in choosing food for health, but will not compromise on taste, but also are strongly being or find barriers in terms of convenience, likes, dislikes, and cost and availability. So just to sum up what we have found overall, so adults in Ireland have low intakes of dairy and fruit and vegetables with respect to recommendation. There's a high proportion of consumers of biscuits, confectionery, and snacks. They have high intakes of saturated fat, sugar, and salt, low intakes of dietary fibre, low intakes of vitamin D, vitamin C, folate, calcium, vitamin A, zinc, B6, riboflavin, and iron, particularly for females. Taste and health are top priorities when choosing foods, and convenience, likes, dislikes, cost, and availability are the biggest perceived barriers. In terms of just some quick comparison to NANS 2008-2010, we can see that there's a lower intake of bread, potatoes, meat, and salt, a higher intake of pasta, rice, and savouries, fruit and vegetables, and supplement use. And there's been no change in the intake of confectionery, saturated fat, total sugars, and fibre over this time period. So thank you all very much for listening. As Jeanette said, if you do have any questions, please pop them into the question and answer box, and I will hand you over to Maria, who is going to present some information on body weight and lifestyle factors.
Thanks, Laura, for a lovely presentation. I'll just share my screen here. So just to introduce myself firstly, my name is Dr. Maria Buffini. I'm one of the postdoctoral researchers who worked on the NANS 2 project, coordinating the UCD team. And my presentation will focus on body weight status and the lifestyle characteristics of adults living in Ireland. Firstly, just to focus in on the weight status, which is an important indicator of nutritional status at the individual level, but also it's obviously important to monitor weight status at the population level and gain an insight into current rates of overweight and obesity, which we know are global health concerns that often coincide with comorbidities such as diabetes, cardiovascular disease, and cancers. So one of the aims of NANS 2 then was to examine the current weight status of adults living in Ireland to see where we sit in terms of the obesity rates and look at the trends over time. BMI, or body mass index, is a commonly used tool for determining weight status, and under, as Jeanette has already mentioned, under normal circumstances, they would be the measurements would be obtained during in-person visits, but we obviously switched to the self-measured weight and height when calculating BMI due to the COVID pandemic and also subsequent social distancing measures. Although some conflicting evidence exists in the literature, there are scientific publications validating the use of self-measured weight and height as reliable tools for monitoring weight status at the population level. So each participant was provided with a set of standardized written instructions, which they were asked to adhere to as closely as possible, using, as Jeanette mentioned, the household bathroom scales and retractable metal tape measure when measuring their height and weight. They also were asked to measure them in duplicate and document them. Height and weight records for each participant then were dual entered into our questionnaire entry software packaged as survey and exported to SPSS to calculate BMI, which is calculated by dividing the average weight in kilos by the average height in meters squared. Each person's body weight or BMI then is classified as per the World Health Organization cutoffs for underweight, which is less than 18.5 kilos per meter squared, right up to those who were obese, or had obesity, which was greater than or equal to 30 kilos per meter squared. So some of the results then, this figure displays the proportion of the population who, according to their BMI, were classed as having either a normal here in the green, or overweight, or classed if their BMI was classed as obese, which is represented by the red portion of the graph. So we have data represented for 991 of our participants. So the total population is reported here, and also we've got that proportion split by sex as well for males and females. And the results showed that 56% of the NANS population were classed as having either living with either overweight or obesity. And when split by sex, it's clear that the higher proportion of males had BMIs which fell into these categories, compared to females whose BMI, who had nearly half of whom had normal BMIs. When we look at the trends over time, so since the completion of the older NANS in 2011, so we've represented the blue here represents the proportion of those who have BMIs falling into the overweight categories, and the red is represented by BMIs falling into the obese categories. So since from 2011 and then the current NANS in 2023, so over males on the left-hand side and females on the right-hand side. And overall, for both sexes, there seems to have been a leveling off of the prevalence of overweight, and even a small decrease from 26 to 18% in males for obesity rates, and a decrease of 21 to 17% in females. So these results are promising. However, I suppose the prevalence of BMIs classed as overweight or obese remains high and is similar to rates observed in neighbouring countries. Interestingly, the results of the Healthy Ireland study here, represented by the orange bar, saw the exact same proportion of those meeting, or of those the BMIs classed as overweight or obese, at 56%. The UK, then equivalent to the National Diet and Nutrition Survey, saw a higher prevalence at 64%. But overall, the rates are similar with what is being reported in Europe. And according to the World Health Organization report, the European Regional Obesity Report, almost 60% of adults were living with either overweight or obesity in Ireland, and they ranked Ireland as the 11th highest country in that report. So although the results we've seen in NANS 2 are promising, in that we're not seeing an increase, the rates do still remain high. Just to describe the NANS 2 population in further detail, we've split, this graph splits just male only by age group. It's not surprising the youngest category here, the 19 to 35-year-olds, showed the healthiest weight profile, and only 9% of those were classed as living with obesity, while the 51 to 64-year-olds displayed kind of the more unfavourable weight profile, I suppose, with nearly 3/4 of males in this group having BMIs which fell into the overweight and obese categories. Weight status data then for the female cohort were more evenly spread compared to males. There was a stepwise increase, I suppose, in the prevalence of overweight and obesity with increasing age. The youngest cohort showed a prevalence of 47%, which increased up to 53% for the over 65s. And this is a relationship we've observed previously in previous surveys. Similar to what we saw in the males, the 51 to 64-year-olds had the highest proportion of those with BMIs falling into the obese categories here at 20% for females also. The next graph then displays the relationship between kind of weight status and social class. We have displayed here those falling into the normal overweight or obese categories, split by social class, from the highest kind of managerial professional groups to the lower semi and unskilled groups. health inequalities amongst those from lower social class backgrounds is something that is observed in many countries, and something that public health bodies are always trying to minimise. However, this gradient still exists in Ireland, and for NANS2 participants, the lowest rate of obesity and the highest rate of those with normal BMI, was seen in the higher social class categories. So there's obviously still some improvements to be made here in this area. Moving on to physical activity levels then, physical activity habits of our adults living in Ireland. Habitual physical activity over the previous 12-month period was recorded using a self-administered questionnaire developed by the Medical Research Council, known as the EPAC-2 or the EPIC Physical Activity Questionnaire, which is the same questionnaire we've used in the previous, in the older NANS of 2011. So it provides a detailed assessment of the amount and intensity of daily physical activity. It includes anything from home-based occupational, commuting and leisure time activities. Just to give you an example, I suppose a participant might have documented sitting at their desk in work for 8 hours a day, 5 times a week. But they'd also do an aerobics class 45 minutes twice a week, and hoover the house twice a week for an hour each time. So all of these frequencies and durations are combined to give a final duration for each specific activity. Individual activities were then grouped together depending on their intensity level to give an overall duration for, sedentary, light, moderate and vigorous activities. And those values then were compared to the recommendations for sedentary and moderate, moderate and vigorous activities as outlined by the World Health Organization guidelines in 2020. These guidelines provide evidence-based recommendations on the amount of physical activity required to maintain human health and prevent many non-communicable diseases. All adults aged 18 years or over are recommended to spend at least 150 to 300 minutes in moderate intensity aerobic activity, or at least 75 to 150 minutes of vigorous intensity aerobic activity throughout the week, or an equivalent combination of both. In addition to this, guidelines also advise that fundamental health benefits are associated with limiting the amount of time spent in sedentary behaviours, including screen time, which we know it's a well-known risk factor for the development of obesity. So how did physical activity patterns of NANS2 participants then compare with these recommendations? And the bar chart here displays the median minutes per week spent in the lighter colour here, moderate activity, and vigorous activities in the darker colour here for the total population and split by sex. So just to briefly give you an example of the types of the difference between the moderate and vigorous activities. Moderate includes anything from climbing the stairs at your workplace to cleaning the house, going for a leisurely walk, going for a swim or gardening. While vigorous activities include things like hiking, competitive running, competitive swimming, that kind of thing. So the median minutes per week spent on moderate activities was well above the recommended 150 as outlined for the WHO report. And this was similar for both males and females, whereas males spent more time in vigorous activities compared to females. And overall, when we look at the proportion of those who met the WHO recommendations, in that they spent a minimum of 150 minutes in moderate or a minimum of 75 minutes on vigorous activity, 95% of Irish adults met this recommendation. So adults in Ireland, seem to be doing well in terms of those recommendations. Bearing in mind, it's an indirect measure, self-reported measure, which is reflective of a previous 12 months, which was during the pandemic. So although it may not be a 100% accurate picture of actual activity. When we look at sedentary behaviour separately then, the median value for time spent in sedentary behaviours for the total population was 35 hours per week, and higher for men at 41 hours per week compared to women, and 3/4 of this was attributed to screen time. although the World Health Organization recommendation is to limit time spent being sedentary, there is no official recommended cutoff time. But from a public health perspective, exceeding 4 hours, 30 minutes per day in sedentary behaviours is generally accepted as resulting in increased risk of things like CVD. And just to put that into context, 4 hours, 30 minutes per day is kind of the equivalent of 31 hours, 30 minutes per week. So we are exceeding that. And in fact, 62% of Irish adults were exceeding this 4 hours, 30 minutes per day. So, and then moving on to, we looked at activity levels, split by weight status. You look at the median time spent in sedentary behaviours and moderate activities, but also sedentary behaviours here underneath, split by weight status. It is clear that those classed, those who had BMIs classed in the overweight and obese categories spent less time in vigorous, moderate or vigorous activities compared to those with a normal weight status. And also, though, they spent more time being sedentary as well. So just to summarize some of the main points of my presentation, although the rates of overweight and obesity have levelled off for adults living in Ireland, rates do still remain high, as over half of adults classified as having are classified as having overweight or obesity, with males displaying the higher prevalence compared to females. In Ireland, there's a social class gradient observed with obesity prevalence, with those in the highest social class categories having the lowest prevalence of obesity. And lastly, although the majority of Irish adults in Ireland met the WHO guidelines for physical activity, sedentary behaviours, the time spent into sedentary behaviours remains high and should be reduced. Thank you all for listening. Hand you back to Breed, I think. Do you want?
Yeah.
Will I move on to the next slide or stop sharing?
No, you could move on, Maria.
Yeah.
I think you have the last slide before
Yeah.
we start. Yeah. So firstly, I'd like to thank both Maria and Laura and Jeanette for the presentations. I think if the participants were here in person, you'd all agree that it's a huge amount of work to undertake these surveys, and there's a lot of results. And these are just the summary results that we're presenting here today. And I suppose in terms of dissemination, firstly to say that this workshop is being recorded, and therefore we will be putting this up on our IUNA website, so you can look at it afterwards, or if you're unable to attend, you'll be able to access it there, as well as the slides. And then we will hopefully have the summary report, and then following on by the full report for the NANS 2 in the coming weeks. And again, that'll be made available on the IUNA website. So I think in terms of, if we stop sharing the slide, we can get going on our panel discussion. We're ahead of time. So we've plenty of time for discussions, and I know there's a couple of questions that come in, so I'll try and get through them. So I'd like to welcome back Maria, Laura and Jeanette, but also welcome Albert Flynn and John Kearney, who are both involved in the survey as well, to the panel discussion. I think overall we can see from the results that there's been some changes in terms of potentially salt and fruit and veg, but also some no changes in terms of other components. So I think to get the ball rolling, I'll ask some of the questions here from the attendees, and please add the questions in. So I think one of the first ones that came in terms of energy and percentage energy, one of the questions was in terms of inside and outside the home, and potentially is the energy that's coming from outside the home artificially low because of the circumstances in that we were in COVID at the time. And I don't know, Laura, Jeanette, do you want to answer this question?
Yeah, I can take that. Yeah, so we're seeing here on average 15%, around 15% of energy coming from outside the home. And in the previous survey, we would have seen on average 25%. We do think that it probably is artificially low due to the times. If we remember, even though we weren't in level 5 restriction, if we could go to the pub or the restaurant, if we had if we were vaccinated and had a cert to show it, people were still staying in quite a lot of the time and were a little bit cautious, particularly at certain times over that 1.5 year period of going out. We did delve into that detail a little bit more, and we can see the same trends there as were there in the older survey. So men were more likely to get, had slightly higher calorie intake from outside the home, and it was slightly higher in the younger age groups and went down as you went up. And that pattern was found in the previous survey as well. But I expect that we're all back socially eating out again, and that it probably is a reflection of the time.
Thanks, Jeanette. Another interesting question that came in terms of, John, and I might get you to answer this, in terms of food choice. And it's interesting that cost didn't seem to be a big motivator, and they were wondering in terms of, I suppose, the comparisons across social economic status, and in terms of weighting and unweighting the data, of course. Would there is that something that can be done, or has it been looked at? So I don't know, John, if you want to come in there.
Yes, I mean, that's an interesting question. It is something we will be looking at. So it is certainly something we can do and plan to do, to look at all of these motivators and barriers by the different subgroups, and break it down by obviously gender, age, and social class. So we haven't got to that point yet. So we were just kind of looking at this point at the top line results. But it was interesting that cost didn't come out, as it has done in previous attitudinal surveys, as being more important as a factor there.
Mm-hmm.
You know?
Yeah. And there's another question here in terms of, I suppose, is the activity self-reported? So Maria, I'll come to you with this one. Or was there any validation of the activity? So that's in relation to the obviously the physical activity in the questionnaire data that we obtained.
As in how did we validate it? Is it?
I suppose it was, it was self-reported. I think you mentioned that, but the validation of that.
Well, the EPAC2 is a validated questionnaire. I suppose it's developed by the Medical Research Council. It was also used in the previous NANS, so it's kind of nice to use the same tool across the two. I know there are other questionnaires available to use, but I think because of EPAC2 was used in the previous NANS, is kind of why we're hoping to use it again this time around. Bríd, you might be a bit more au fait with some of the other questionnaires available.
Yeah, I suppose, to note, physical activity, when we measure it via a questionnaire, it's an indirect measurement. It's not directly measured. And we know that there's issues in terms of that and the validity of the reporting of that, but that's with every questionnaire you would use. And we just can't do direct measurements. We can't do everything in these surveys. We'd love to, but we can't. But I think the good thing with the EPAC will be to look across, because we've not only used it for NANS, we've used it for the North-South as well. So even though there may be issues in terms of the over-reporting, we can still look at that trends using the same methodology. So that will be interesting. And I think what is interesting coming out of that physical activity is the sedentary behaviour. So I think this is something that we really need to look at, and I think there's loads more research coming out in that area in saying that it's an independent risk factor, and that's something that we need to be considerate of. So I'll move on, and I think there was a question in terms of, and Laura, I might aim this at you in terms of the supplementation from Mary, in terms of 7% of premenopausal women taking 400 micrograms of the folic acid supplement. But in terms of, there's more taking multivitamins, and potentially is there, I suppose, folic acid coming through from that?
Yeah, absolutely. So when we looked at the women of childbearing age, we had about a quarter of them taking a supplement that contained folic acid. And as you said, there was more coming from those multivitamins and minerals. As you know, in those multivitamins and minerals, there can be a wide variation of what's contained in them or the amounts. So we have some multivitamins, minerals that are very low in terms of folic acid, so like 1, 20, 40 micrograms. We have some that are up around 400, but the average dose of folic acid per supplement in those multivitamin mineral categories was about 250 micrograms per day. And that tallies kind of in with the about a quarter of women of childbearing age who were taking those supplements containing folic acid. They were getting about an average of 260 micrograms from those folic acid supplements. But it's quite low in comparison to that 400 recommendation for sure.
Thanks, Laura. There's another question in terms of the salt, in terms of the difference in salt intakes, in terms of the urinary salt from NANS and NANS 2. I don't know, Jeanette or Laurie, do you want to comment on that in terms of the change that's seen? Jeanette, I'll go to you first.
Yeah, there's quite a change, positive change, which is great, between the two surveys. So we're looking at almost a 20% lower salt from urinary salt excretion. We're still well above the 6 grams a day, but certainly it's good to see it coming in the right direction. And we may expect that this is partially due to the reformulation and the work that's done in the voluntary reformulation of salt led by the FSAI. So we are seeing it coming down across a lot of categories. Yeah.
Yeah, it's good. Another, and I think an interesting one is, were we surprised by the outcomes of the survey? It looks like diets still need to improve in general, and we haven't moved much in a more positive directions. And thanks for an excellent presentation. So I don't know who wants to kind of very much top line overview there.
I don't know, I suppose I can get, everyone can give their thoughts.
Yeah, their opinion.
I suppose from an academic and from my knowledge perspective, yes, but from a real life perspective, I know myself, and COVID was, in some sense, COVID was really good for people. A lot of people seemed to take up activity and did really, start cooking more home. But then when we started to go back into, and I'm speaking on a personal basis, when we started to go back into our normal patterns, life does take over a bit. So that's where I think the food choice and eating behavior comes in really nice alongside, our dietary intakes. We might, us even, I'm not going to speak for everyone on this panel, but we know what we're supposed to do, but how you can motivate yourself and get yourself to do it is another story. So that's my take.
Yeah, sure. Albert, yeah.
I'll let Albert come in first if he'd like.
No. Albert, you're just on mute there if you wanted to come in, I'm not sure.
No, carry on that. Yeah, carry on.
Yeah. Okay, go on, Jen.
Again, am I surprised? I suppose we look very closely to what's happening in other countries across the world as well, and we're seeing these same issues in the developed world in general. So there was no real surprises. That doesn't mean it's a good thing, but and again, with numbers, we weren't sure would there be slight shifts up and down in certain food groups or nutrient intakes. But no, not necessarily surprised. There's another question I saw there about, where do we go now from there? And I think that's one that will be interesting to discuss in a minute. But for the most part, we're not any different than any other developed country in this way. Our food, our food choice has changed. The fact that we're eating less outside the home, or that our data for this survey are suggesting that, that we're consuming less outside the home, with only 15% of calories coming from outside the home, and for us still to have those high intakes of salt, sodium, fish, sugar, which has been generally blamed on the outside the home environment. Again, it makes us need to look at what we're consuming within the home, because you can expect that's only going to be exaggerated when people are now, when people are back eating as normal and consuming more outside the home.
Okay. I'll go back to you in terms of barriers to healthy eating, John. There was a question that came in there in terms of the way they were ranked. So convenience was the first one. Is that it's the primary barrier that we're seeing?
Yes, in terms of barriers to healthy eating, that would have been the top ranked and kind of first choice perceived barrier by the total sample. So yeah, I mean that has come through in previous attitudinal surveys, maybe not quite as the top ranked, but because often cost will be higher. We do see taste emerging also as being something that people don't want to compromise on. I think it's interesting that people, believe in some ways that healthy eating means a compromise on taste, and also for some reason that it is inconvenient. So certainly, I would think for something like the food industry, if they can kind of somehow, obviously, produce healthy foods, which obviously will be convenient, but which are healthy, of course, above all, then that might be something which would fit that. It shows that sense, because we know as a motivator, healthy eating is there for people. Nutrition and health is up at the top. So there is just this sort of conflict, if you like, between the two. However, what I would say is it will be very interesting to break these results down. Obviously, these are just top lines, so to look at them, across different socio-demographic groups is going to be very interesting.
Yeah. Look forward to that. I think Maria, just a question here from Mary in terms of, I suppose, the accuracy from we self-measured height, but I suppose weight as well. You could also put in there in terms of were there instructions given? Did it included second adult to take the measurement? I suppose in terms of the validation of the self-measured height and weight that we did.
Yeah, no, it's a good question. And I should have mentioned actually that we did carry out a validation, a small cohort validation study of 100 adults as part of a fourth year project, where we asked 100 sort of males kind of around the UCD area, males and females, to carry out the same task as the NANS 2 participants, using the same set of instructions to self-measure their height and weight at home. But also then we'd ask them to come into UCD for at a scheduled appointment to have these measurements taken again by a trained researcher. And when we looked at the stats on that, there's no significant difference between the self-measured and the researcher measured height and weight, or the BMI calculated from those measurements. And we have compiled those results into the manuscript for publication. We're hoping to get that submitted in the next few weeks. So we'll share that as soon as it's ready.
Yeah, it was good to see that the method, I suppose our instructions were very clear in terms of how a participant would measure their own weight and their own height. So it was good to do it and to see the results. Waist and hip circumference weren't so comparable. Just to note, we did do that as well, but
nobody knows how to do that. Yeah,
no one knows how to measure that. So that's where we saw the difficulties. Another question in terms of, I suppose, from the other methodology, Helen has a query. Was there any concerns with the self-reported in terms of people not being honest or fully reporting their poor eating behaviour? And maybe that goes back to how we did the dietary recalls. I don't know. Laura, maybe you want to come in on that.
Yeah, so look, we know with any type of dietary assessment that there can be that risk of people both under-reporting and over-reporting certain types of foods. I suppose we pride ourselves on the relationship that our field workers get with the participants, and the relationship and the rapport that they have, that while they're conducting, whether, in the previous surveys it used to be a face-to-face review of the diary, or now the telephone 24-hour recalls, that they make participants feel very comfortable. There's no judgment. You have kind of a chat as you're going on through it, and sometimes somebody will say, oh, but I was at a match on Saturday, and did you have anything at the match? Yeah, there was a Chuck fan, or that we really do pride ourselves on that relationship between the participant and the researchers, and we think that allows us to get a very good, as best representation as could be gotten in this circumstance. Again, We will also have in the coming months some results coming out from the comparison study of how the food diary will compare to the 24-hour recall. We're currently analysing those results, so we don't have them for you today, but that will kind of show us as well if there's been any change from the methodological, from the diary to 24 recall. Is it because of that change, or is it a true change, or how we can interpret those results as well? So I see that was one question which kind of ties in there.
Perfect. Thanks, Laura. There's another question, and maybe Jeanette, I'll direct this to you in terms of sugar sweetened beverage tax was introduced obviously between NANS and NANS 2, and can we see that effect in terms of the tax in terms of NANS 2? I suppose.
We'll obviously need to do a little bit of analysis to answer the question in detail, but yes, absolutely, we are seeing a move towards lower sugar sweetened beverages, but I think it seems for the most part to be driven by industry, because most of what's available now are lower sugar, either no sugar or very low sugar for most drinks that are available. So for most carbonated beverages, and even in terms of cordials. So we have seen it, Laura presented it there, and you can see that there is that shift from what we would have called full sugar, your 13 grams for 100 grams of sugar in a carbonated beverage. So we can see that people are now taking the other option, but I think that is being driven by industry and obviously by the sugar tax for sure. But we will be able to answer that question to a large extent as well with analytical data, and we'll be doing so very shortly.
Perfect, thanks. There was another query in terms of the obesity rates, Maria, in terms of the manual skilled workers have the highest actual rates of obesity, higher than unskilled, and was this a surprise in terms of that result?
Yeah, I suppose I was expecting to see a stepwise increase in the rates of obesity with decreasing social class. So they are kind of, I don't know if it's to do with the numbers within that group as well, or sorry, I'm trying to bring up the graph here. But I suppose the take-home message is that the highest social class did show the highest, sorry, the lowest rates of obesity and the highest rates of normal BMIs. So do you have anything else to add to that, Bridget?
I suppose, yeah, like you said, Marie, you would have thought that there would be that stepwise, and we have noted it in other population groups. This isn't a new thing in terms of social class. It's those lower social classes seem to have the higher prevalence in terms of overweight and obesity. In terms of this one, it could be, and something that we could tease out potentially is looking at, I suppose, how we categorize social class. Now we go with the CSO and how their methodology is, but then you have your students sitting in these lower social classes, and that's just in terms of the methodology. So it could be that that's slightly affecting what we're seeing. But I think that the overall message, as you said, Marie, is that the higher the social class is, that they are the lowest in terms of prevalence of overweight and obesity, and something that we really need to look at in terms of overall socioeconomic status. Okay, I'll move on to another one in terms of Marianne, in terms of, do you think that mixed and ready-made meals, are making it more difficult for people to self-report what they've eaten? The vegetables, for example, in a shop-bought curry rather than they prepare them themselves, and maybe that's in terms of how we, I suppose, delve into looking at fruit and veg and their intakes. Don't know.
I can Jeanette can jump in if she wants. Certainly, I suppose when you ask that, you could say, yes, that might make it more difficult. But again, we collect all of our information at brand level where possible. We ask participants to retain the packaging. If they don't have the packaging, we actually either go out and get it ourselves or contact manufacturers as well. So in terms of the participants' ability to self-report, it may be a little bit more tricky, certainly, but we do our very best to get accurate information on those brands and the types of foods to be able to, and again, we haven't had the chance to disaggregate those vegetables from composite dishes yet, but again, it's something we are doing, and having that brand level detail with packaging, photographs and information from manufacturers on the ingredients and breakdown is very, very valuable in that regard. Jeanette, maybe you might want to add anything there.
Yeah, just to agree with what Laura said, but also to say that we take that burden from the participant, and that burden goes onto Laura's desk for the most part, the field workers' desks first. But The way we collect our dietary data, and we always have, is to get all the information that we can from the participant, including the packaging, and we get really, really detailed information. And that leaves the burden back with us and Laura, for the most part, in terms of understanding that food composition and understanding and breaking it down and disaggregating at a later stage. But I can't emphasize enough how important it is to collect that real detail at brand level, and not just to answer the questions in terms of nutrition, but particularly in terms of food safety, to be able to disaggregate all that data at a later stage. So while we may have taken some compromises in this survey in terms of our social distancing, we certainly didn't in terms of the data that we collected. And the participant was well able, for the most part, from what we can see from diaries, to report what they had and to understand what they had consumed. And as I said, the burden came back then to the research team to understand that composition and to be able to break it down at a later stage.
Okay, thanks. Jeanette, apologies now, I'm jumping around. I'm trying to get to everyone's question. There's quite a lot coming through, so apologies if I don't get them to all of them. I just noted one here, and I suppose it's in terms of looking at the nutrient intakes and the DRVs for them, and which ones was actually used. Was it the EFSA values in terms of AR or PRI? I don't know. It's probably dependent on the nutrient itself, but Laura, do you want to note?
Yeah, again, so for what we presented today here, it's just been a snapshot, and when we do present at a later date, we sometimes delve a little bit more into those. But I suppose, for the fat and the carbohydrate, we use the SACN, the UK SACN recommendations. The reason being that they give a value for which your average population intake should be below, so we could compare that to the values that were reported today. EFSA do give the ranges for which we'd have to look at the percent above and below, and we just didn't get that done in advance of today. In terms of the micronutrients, it was the estimated average requirement that's used to assess adequacy. And for the most part, we use EFSA where available. If EFSA don't have an estimated average requirement available, like for vitamin D, we use the IOM 10 micrograms, or for some of the ones that they don't have, I think maybe one of B vitamins, we referred back to the UK Department of Health. Again, the saturated fat was UK Department of Health because it's an average population intake, and dietary fibre is an adequate intake from EFSA. So it's where possible, we do refer to EFSA, but sometimes depending on the type of DRV and the use of it, we have to refer to other ones as well.
Thanks, Laura. There's a question here in terms of the physical activity findings, and again, the majority of adults, am I right in thinking that the majority of adults are meeting the physical activity guidelines set out by the WHO? Maria, do you want to, or I can come in there?
Yeah, the majority of them, 95% are meeting the bare minimum now of in terms of the moderate or vigorous activity, in that they spent either 150 minutes, at least 150 minutes, or in moderate, or at least 75 minutes in vigorous activities. Again, it includes everything from, it's not just kind of going out to do your gym session, it's anything from an occupational activity to recreational commuting, and also that recommendation, so it's 150 minutes that's spread out over a week. So it's actually very easy to meet that, if you think about it. So I don't know whether they need to be higher, but also I think just when you look at the sedentary behaviours, they really need to come down, because you might have, I suppose, you might have gone to the gym or gone out for a walk, but if you're sitting for the rest of the day, then you're still at risk kind of cardiovascular disease and things like that. So, yeah, I don't know if that answers your question. But do you want to?
Yeah.
Yeah.
And I suppose, again, to note in terms of it is an indirect measurement, and the caveat is with that, and they tend to overestimate, or people overestimate their recreational activity, so their actual physical activity, actually, and underestimate sedentary behaviours. So it's just to consider that when we're looking at these results. Maybe John, one from you, or in terms of qualitative data and what was collected, were people given a chance to report additional barriers to healthy eating or motivations in terms of food choice that weren't in the list provided by the investigators?
Well, there was one kind of a category which was other. However, there was, to be honest, this was quite limited in terms of the proportion of respondents that use that. And so there was kind of no additional, if you like, motivator or barrier that kind of exceeded 2%. And hence we didn't report on that. So to be honest, it was very much a quantitative and pretty much closed-ended questions, but obviously giving the respondents, if they so wished, an option for other. So I wouldn't have said, you know, in any way that we could call this, you know, open-ended questions with where we were eliciting told, if you like, what were for them the main barriers or motivators that way.
Thanks, John. Actually, I don't know, Albert, maybe you want to come in this because is Ireland likely to update their RDAs for micronutrients for the Irish population ID update 1999 documentation that we have? It's an interesting one.
I'm not sure if there's any plan to update that document from 1999. Perhaps it has been superseded in any case by the EFSA recommendations. And the EFSA recommendations have kicked in since then, and indeed they're updated now on fairly regular basis, certainly for the key nutrients. So I'm not sure if it's necessary to have a national set of recommendations, because we've got such good recommendations now from EFSA.
I agree. I'm just trying to see now. I think an interesting one here, I think we've queried it all the time, is in terms of the compensation that we give to participation in these surveys, and just wondering, could we get a more representative sample of social groups, or would this bias it? I know I thought it'd be great to have a more representative sample in terms of trying to get that lower social classes. We're struggling in the last few surveys. And it's a difficult group to get. And I think overall trying to get people to take part in research is trying. So, you know, we're always trying to come up with ways in terms of how you would do that, but keep it representative in terms of accessing the population. I don't know, Jeanette, have you any comments onto this?
No, we've recognised this as an issue for a long time, that it's really difficult to get that representative sample in terms of social class. And I think it goes back to a comment you made earlier, that perhaps we're looking at social class, you know, that maybe we need to move forward in the way that we look at social class, and that mightn't be the best way to do it using the CSO, values. We did use the social deprivation index this time round as well, to, like, we identified the clusters, and then within the clusters to identify areas that may be considered to be more socially deprived. But even with that, again, you're going to, we had to take everyone who contacted us for this survey, you know, take that household at least in the first instance. And it was, yeah, it's really difficult to get people to take part in a survey, and it's getting more difficult. And we do give an incentive, but really, and we can't give any more than that. It's a budgetary thing, really, and you know, even as is. So I'm not sure that I've answered the question, Breach, but it's something we continually work on, and our field workers and our research teams work really hard on this. And from our sampling plan from the beginning, we always try we really do try our best to make it as representative as possible across all of the different demographic factors. But it is difficult. And
yeah, I think in other countries they kind of target that particular group as a sole
separately.
group. Yeah.
Yeah.
I don't know whether that's the way to go, but I suppose, yeah, it's hard. It's hard to get them.
If I might jump in there again,
Yeah.
as you said, Jeanette, like we have the incentive, but in order for us to get that nationally representative sample, we had that hierarchy in households. So even sometimes if we got, so first of all, the onus was on every household to contact us, which is a big challenge. And then secondary, if they did contact us, if, you know, maybe somebody in that lower socioeconomic household was interested in taking part, if they didn't meet the hierarchy, and the person who was within the hierarchy didn't want to take part, unfortunately, they didn't take part. So we tried to keep that to avoid biasing the sample of somebody who wanted to take part and try and get a representative sample. But I don't know if the incentive didn't swing it one way or the other. And for the most part, I don't think so. I don't have an answer either. I don't know, does anybody on the call have an answer, but it's something we definitely need to work on.
Yeah. Okay, I'm gonna just maybe ask one because I see it's come up here twice, and then I'll maybe try and do a summary one. Just in terms of Jeanette, the urinary salt or measurement and its comparison against, I suppose it's the spot one that we do in the comparison to a 24-hour urinary collection. I don't know, just a comment on that.
We'd ideally love to collect 24-hour urines from all our participants and everything else. It's not feasible in a national survey, and we had some good data on urine volumes which we were able to use, and so we've been able to fairly reliably give a population level for salt. We feel that that's spot urines have been shown to be reliable at population level, but at individual level, obviously, we wouldn't be able to report anything on an individual level in that regard. Albert is an absolute expert on salt and might want to come in there to add something to that, but this will be a method that will be used and is known to be quite reliable.
I agree with that. Indeed, it is very difficult to incorporate that in. I think the best you can do is rely on a validation study, which will basically be used to calibrate the spot urine collections. And it may be possible to do those types of studies within a larger survey, but it would have to be on a limited sample because it is very resource intensive to collect 24-hour urines. But I think you can use that type of subsample or sub-study to calibrate the spot urine collection.
Yeah, and I might come back in here. I know Geraldine Coskelly is on the call here today, I think, anyway, at the webinar, and she may well have asked the question, but she's doing some work on diurnal, sampling more than just your morning sample, and I'm talking closely to her on that in terms of methodology for the future. It may be a case that we might need to take more than one sample, and if we do that might be better than just the morning sample. You're always looking here at the cost, the burden to the participant, the cost, the budget, and what the key questions that we have to answer within the survey. And, being out in the field, it's very difficult. A lot can be done on site and, for clinical research at individual level. But when you've got a population-wide survey, collecting biofluids is complex. And we will always do what we can to validate the measures that we're using. And again, as I say, I'm talking closely to Geraldine Coskelly in relation to potentially changing that methodology going forward to improve it again.
Mm-hmm. Thanks, Jeanette and Robert. I think in the essence of time, and to keep it to time, what I'm going to do now maybe is to kind of ask the PIs in terms of what would their take-home message, I suppose, from this be. And I suppose there's questions in there in terms of where do we go with that? Like, what do we need to consider next, maybe in terms of policy or anything like that? So I don't know who wants to go first. Very open question. John, do you want to come in, maybe?
Sure. If you're asking me, I guess what, and this is from the whole survey, what the kind of main key kind of take-home messages would be. Well, I suppose first I would say, and maybe I'm biased, but the importance of getting some attitudinal data to accompany the behavioral data on diet and physical activity is very important, so that we can ask those questions of why people are eating the way they are or behaving the way they are. And I think that's very important for helping us then, provide more targeted and hopefully successful interventions. In terms of kind of the overall findings, I think I know we can be heartened by a slight increase in fruit and vegetables, but I'm still of the mind that really our intakes are very low, and I do believe from a public health nutrition perspective we have some ways to go to increase intakes of fruit and vegetables. And also in terms of the activity, I just think very interesting finding was a high sedentary level of sedentarism, and I really do think that's something which needs for sure to be tackled, because as you said yourself, that it is an independent risk factor, and so I think it has to be certainly the subject of further work going forward.
Yeah. Thanks, John. Albert, do you want to come in next, maybe?
Yeah, I'd just like to make 2 points. One is I just want to congratulate the team on what has been a very successful collaboration across 4 institutions to complete this study against what proved to be enormous odds. In March 2020, we thought this was all over, but as I said, the team pulled together and they got it completed, and I must say, well done to all. The second point is that I want to acknowledge the funding from the Department of Agriculture, Food and the Marine FIRM program, the Food Institutional Research Measure. It's important that this research area is recognized as a priority for funding under the FIRM program. And indeed it has been now that this particular study marks another milestone in this research, which goes back now for FIRM funding for more than 25 years. And there is a good reason why this is regarded as a priority under this program, because it's recognized that it has a very high impact. And we've seen that these studies produce data which is very, very widely used. That's partly because the data is of such high quality and it's nationally representative, and it's essential for food safety risk assessment. It's essential for the development and implementation of nutrition policy. And indeed, it's essential for the food industry. The food industry has a lot of interest in understanding the role of their products in a healthy diet. And there's an enormous focus now in the industry and indeed among policymakers on reformulation of food. So this data is of enormous value. And we see the wide use among the agencies like the Food Safety Authority of Ireland, Department of Health and Children, Department of Agriculture, Food and Marine, Safe Food, and other agencies nationally who have used this data. We've seen it internationally. The European Food Safety Authority used the data. The European Commission has used it. And of course, it's widely used in the research community. We see a very large number of scientific publications that have been published over the years using the data from these studies. So the high impact of these studies ensures that it maintains its high priority for national research funding. And again, I'd like to acknowledge the Department of Agriculture, Food and the Marine and the FIRM program for that.
Thanks, Albert. Jeanette, I'll go to you next.
I might firstly thank Albert for articulating what I tried to say earlier so well and with such authority, and thank you. And I'd also like to thank you for the conversations that we had in March 2020 and following it, when we really were unsure what we were going to do with this program and how to manage it, and many long phone calls to reassure us that we can go on, and that you know, that there are other ways of doing this. And as I said earlier, to thank FIRM as well for their patience at that time with us, and the trust in us to carry out this survey, and to be, you know, to be so assured that the data that we can provide under these circumstances would be valuable, and we really feel that they are. To answer your question, Breach, would you to comment on it? I think we should also acknowledge the work that is being done, particularly from, led by the Food Safety Authority of Ireland in terms of reformulation. We're working very closely with the Food Safety Authority of Ireland in terms of reformulation for these nutrients that are high in our foods, such as free sugars, salt, and saturated fat. And hopefully we will see, when we come back and do a new survey in the future, we'll come back and see that there has been an impact of those. It's certainly not from want of trying, and the efforts from the FSAI here are huge. What has been nice in this survey, I think, to see is the efforts from the vitamin D supplementation recommendation and all the work that went into that, again, led by the FSAI with, researchers and academics in Ireland to put together that report that recommends a supplement for vitamin D. And we have seen, even though that the levels of inadequacy for vitamin D are still very high, it's nice to not see those 80 and 90% inadequate, because it really did feel like it wasn't even a talking point. It was so high previously that you couldn't even see where it was going to go. And to turn around today and see that we're now, at 50, 60%, I'm not sure the exact number of inadequate intakes, it means that there is room for more improvement, and that there are a certain amount of the population that are adhering to these recommendations, and therefore it's easier to encourage more, I think. Overall, there's still work to do. I think we're absolutely delighted to be able to collect data now on the very young children again, and to see if there's any changes there. And maybe that's where we need to start with the children. Habits, we've seen and we've shown many, many times that habits that are formed in children and in adolescents carry on through adulthood, and a lot of the changes probably need to be made at an earlier stage. I'm still advocating for home economics in secondary schools, and I think it's really important to have those life skills. And in secondary schools, I think it's really important that people take, and for maybe that some of this becomes more mandatory at secondary school level. So that's my take home, I think, on it.
Thanks, Jeanette. I suppose I'll add to that in terms of the weight status and physical activity. I like, it is good to see that we do see some sort of decline. It's kind of plateaued and we're kind of going over the other edge, because we were predicted to ever increase and be one of the highest. So I think that there is positives in what we're seeing, and in terms of potentially physical activity. But again, sedentary behavior is something that we need to understand more. So I'd just like to add that on, but agree with everyone else's comments there. I suppose in terms of closing out the workshop, again, to thank everyone, to thank the department, again, to thank the team behind this. As Jeanette put up, it's a huge team that undertakes these surveys, a huge amount of work, especially the field workers that have to go out and do the day in, day out, gathering the data, and to the postdocs as well to try and organize it all. So a huge thanks to them and to the participants for them taking part. It's always hard to get them. And finally, thank you to the panel members today, especially those that were given presentations, and John and Albert for contributing to the discussions. It was great to have. Some things to note again is that this webinar is recorded. So we will make it available hopefully in the next few days in terms of the recording of it, and it'll go up on the IUNA website, and hopefully we'll maybe put a tweet or whatever out when we get that up there, so you will have that available to you. And apologies if I didn't get to answer all the questions. There's quite a lot of questions, and I know I didn't get to cover them all. But if there's any pertinent ones that you want to request of us, or just directly contact us, I'm going to ask the email address is the same if you want to contact us through the email address that you got the webinar link for, and that's the IUNA website. And I know there was a query in terms of data access as well, and data access is available through the usual channels as in terms of the other surveys as well. So again, if you contact us directly through in terms of the IUNA email or Gmail address, we can talk to you about that. I think that covers everything. I haven't forgotten anything, have I? No. Okay, that's great. So thank you all for attending, and we'll leave it there.